Coming up in the next half hour.
I just was taking a shower, washing, and then I felt a lump.
Breast cancer, where courage meets compassion.
So many people keep telling me how strong I am, and it's not that I'm trying to be strong. It's just I have 4 kids that need me.
Meet 2 moms ready to put it all behind them.
Since the moment I was diagnosed, I wanted to get this thing out of me. We're now on the healing side of it.
Yes.
Plus, the science and expertise empowering survival.
Someone you love will live because of this cancer center.
Welcome to the Morning Medical Update. Cancer, choices, hope, and science. We're coming to you from the Dolph C. Simons Jr. Family Broadcast Studio here at the University of Kansas Health System. I'm Jessica Lovell. Today, we are meeting 2 of the estimated 300,000 people in the U.S. diagnosed with breast cancer this year. Our first patient worried cancer would rob her of the things she loved. As Janine Kiesling shows us, the diagnosis came as a shock and was wrong.
I got a notification on my phone, oh, you have a new message or whatever in your chart.
Allison Lackey couldn't believe what she was reading.
And it said, highly suspicious of malignancy.
The message, delivered over a weekend, sent her searching for answers online.
Going down a rabbit hole that I didn't want to go down because that was a scary, dark place.
Unfortunately for this Lee Summit mom, things only got worse when she was able to talk with her doctor.
My initial diagnosis came through another hospital, and it was the pathology that they gave me came back showing that I was triple negative. That's a really bad diagnosis to have.
Allison says the fear in her was telling her to start treatment immediately, but her gut was telling her to get a second opinion. Friends and family convinced her to follow her instincts, and she says that decision likely saved her life.
The reputation mostly is why I wanted to go there, but I did have my friend from church did her treatment through KU and was very happy and actually recommended the oncologist and breast surgeon that I have.
As soon as Allison made her appointment at the cancer center, she knew she was in the right place.
They were able to make meetings, appointments with everybody I needed to see all within one day.
Hello.
So the oncologist, the breast surgeon, the radiologist, all of it in one day.
These are the first lymph nodes that drain the breast.
Even before those appointments, Allison knew exactly what to expect.
I hadn't even had my appointment yet, and there was a courier who hand-delivered a personalized packet from KU outlining who my doctors were and what to expect, and it was just so reassuring and wonderful that they made it personalized.
Allison's doctors at the cancer center scheduled her treatment immediately, but they weren't satisfied with the previous lab results from the other hospital, so they ordered their own. Turns out Allison was misdiagnosed. She didn't have triple-negative breast cancer. On the day her treatment was to begin, Allison's doctors changed course, and the tumor shrunk.
Thank you. Thank you. All right. Okay.
All right, we're gonna back into your room.
Okay.
Allison had a lumpectomy to remove the tumor, and after a few radiation treatments,
So this is our game room. We don't do a lot of, going out to concerts on the weekends. This is where we spend our money on these games.
she expects to be back playing board games and going for walks with her dog Comet by Thanksgiving.
I'm gonna have a whole lot to be thankful for.
And we certainly are thankful Allison is joining us right now. Allison, we are talking to you less than a week after your lumpectomy. How are you feeling?
I'm feeling okay. Of course, a little soreness and a little bit of limited mobility on the right side of me, but I'm doing great.
Well, as we just heard, you were misdiagnosed with triple-negative breast cancer. What emotions were going through you when you finally learned the correct diagnosis?
Well, relief, obviously. It's a more treatable situation when it's not triple negative. And so knowing that I had more options available as I began my treatment, it was a sense of relief.
You spoke of a personalized packet to help guide you through your treatment. Can you tell us a bit more about that? What did you receive?
Yeah, sure. I've actually got them right here. I got my appointment guide, and as you can see, it's got my name on it. It's personalized for me. This happened 2 days after I set up my second opinion appointment. actually, it was one day after I set up my appointment. That was hand delivered. And then last week, about 5 days before my surgery, I got 2 more personalized packets with my treatment guide on what to expect throughout my surgery. So it's just really amazing to me that my treatment is just as unique as my diagnosis, as my cancer. And that was one thing that surprised me, was how different breast cancer is for every woman.
Everyone who completes chemotherapy has a chance to ring the bell. You had a lot of people in your corner, as we can see. Who are some of these folks cheering you on?
Well, in the background, you see the team of nurses. I had to go for 20 weeks for my chemo treatment. I had 2 different phases, but in the background, you can see all the nurses who helped me. That's my daughter, Emma, and then my daughter, Annie, right there, my 2 girls. And then also there, I had my 2 sisters. They were in charge of making T-shirts. You might notice in the video there, it says Team Allison. And so they made the T-shirts for everybody in my family. That's my mom and my dad right there. And so I have my 2 sisters, my mom and dad, my 2 daughters, my brother-in-laws. My husband, of course, has been my biggest champion. My husband, Ainsley, has been by my side from day one, and I'm so fortunate to have such an amazing support team. I love them all so much.
What else do you need? And next to me, sitting here at the table, is some of your very favorite people, Allison, our breast cancer experts here at the Cancer Center. Closest to me is Dr. Ann O'Day, breast medical oncologist and medical director of the Breast Cancer Survivorship Program. Good to see you. In the middle is Dr. Jamie Wagner, surgical oncologist and division director of breast surgical oncology. Good to have you. And across from me, Dr. Shane Steckline, a radiation oncologist. Dr. Wagner, so why do patients need chemo prior to surgery?
Well, we first want to, as Allison, I think, so eloquently stated, that we are in an era of breast cancer treatment where we right size according to the, quote, personality type of the breast cancer, right? Breast cancer is like a family with a lot of personalities now, and we want to right size that treatment. Not all patients need chemotherapy, but when we know they will benefit from chemotherapy, there is benefit of getting it prior to surgery, what we refer to as neoadjuvant chemotherapy, meaning chemotherapy before surgery. In those specific situations as it pertains to surgery is we have the opportunity to reduce the size of the cancer. So patients that may have been borderline lumpectomy candidates are now better candidates to proceed with lumpectomy. We also know that it will equally start treating the cancer that could be in lymph nodes, or even when we've diagnosed cancer already in lymph nodes, it can treat it such that we can re-examine them at surgery to see if the cancer has been eradicated and preserve lymph nodes. And Dr. O'Day can absolutely speak to, from the systemic therapy standpoint, how this can make a big difference in their treatment and outcomes.
Yes, thank you so much, Allison. We're so grateful to you for sharing your story and so beautifully articulating this and some of the messages that we really try to drive home when we're empowering our patients to really advocate for themselves. And you've done that so beautifully, you know, by coming and getting a second opinion. We were able to have a team of expert breast cancer pathologists review your biopsy and determine that there was actually some hormone expression within your cancer. And this is such an important mainstay of treatment for patients that have that type of breast cancer. So it really is so wonderful to think about the fact that because you came here and because our very specialized pathologists were able to identify this, you're going to be able to benefit from one of the most important parts of your treatment, which is hormone-targeted therapy. I do think Dr. Wagner and I would really love to share some news with you today, and that is that we just got the results from your surgery, and all of your cancer is 100% gone.
Wow.
We just got it last night, and I shared it. Came to my in-basket yesterday late afternoon, and I shared it with Dr. O'Day, and we were talking about it this morning, and we are so thrilled. Like, this is what we want to see
so
for our patients.
This is the ultimate breaking news moment.
Yeah.
I love it. I have chills.
For nerds like us.
Right, I love it.
I know.
Superboy.
Yeah.
Love it. Oh my gosh, Allison, just congratulations is an understatement. Just so glad to hear this news and know you're doing well.
Thank you. Thank you. Thank you so much. I can't say it enough. I just can't. I owe you my life.
You did all the hard part. You did all the hard part.
So Dr. Wagner had mentioned this big family of breast cancer types. Dr. O'Day, tell us a little bit about triple-negative breast cancer. That's what Allison was originally diagnosed with. What is that?
Yeah, and so when we think about breast cancer, there's sort of three main subtypes, and they all are dependent on the expression of different types of receptors. Two of them are commonly referred to as hormonal receptors. That's the estrogen receptor and progesterone receptor. But the third one is a growth factor called HER2, which is present in about 15% of all breast cancers. And so there are cancers that don't express any of those receptors, and those cancers are nicknamed triple negative. I always say we shouldn't think about that as triple negative or triple bad. I wish that it was called triple absent, because what it really means is those receptors are absent. They're not on the surface of the cancer. And if those receptors aren't there, then it won't benefit the patient to have those receptors be targeted. If they're not there, we can't target them. So we have to use other types of therapy.
Dr. Wagner, how do you determine if someone needs a lumpectomy versus a mastectomy?
It really comes down to how much cancer is in the breast. What is what I refer to as the tumor to breast size ratio. How much cancer do we have? How much breast tissue do we have? At the end of the day, the cornerstone of cancer surgery for breast cancer is getting the cancer with a cleaner of tissue around it. Right? And if we can do that and cosmetically also leave something that is appropriately pleasing for the patient, we have a lot of ways we can do that even with a lumpectomy, then a lumpectomy is an excellent choice.
So let's head into the OR with you. You're using a device, has kind of a weird sound. Let's listen in for a second. Okay, our videographer said it sounded like a synthesizer at a Styx concert or something like that. So what is this device? What does that sound? What does that mean?
So this is the device that we use to identify sentinel lymph nodes. Sentinel just means first. So a cornerstone and an incredible advancement that we have made over the last couple of decades of breast cancer treatment is not removing lymph nodes that are healthy. Lymph nodes provide a lot of benefit to our body. Where we used to take them all out from the beginning, we now have techniques and tools to be able to figure out what is the natural lymphatic drainage pattern of the breast, because that's the first route that the cancer would try to take. We want to identify those first lymph nodes during surgery, and that's what this is really doing. It's identifying the technetium that drains through the lymphatic channels to tell us what are those first lymph nodes, because that would be the first landing spot for the cancer. And we want to test those. If there's no cancer there, fabulous, we're done. But if there is cancer there, that's incredibly important information for both Dr. O'Day and Dr. Steckline to be able to determine what is the next line of treatment, how do they want to deliver that. So it's really pivotal information to the entire team.
So Dr. Steckline, thank you for waiting patiently. So if the tumor is out, why would radiation be necessary?
So in Allison's situation, the purpose of radiation is that it enables breast conserving therapy. We know from multiple studies that were done decades ago that doing a lumpectomy alone is associated with an unacceptable risk of recurrence for most breast cancer patients. That tells us that even if Dr. Wagner does a technically perfect lumpectomy, there's a risk that there are small deposits of cancer cells left behind in the breast. Radiation is exceptionally effective at reducing the risk of recurrence, and it makes that risk equivalent to if the patient had had a mastectomy.
So let's talk about proton therapy for breast cancer. Why not for everyone if it's tissue sparing?
Yep. So we hear this question a lot, and in reality, most breast cancer patients won't benefit from proton therapy. There are a couple of situations that are relatively uncommon where it's a tool that can help us. Some of those include patients who have some very specific genetic inherited cancer predisposition syndromes, patients who have complex or atypical thoracic anatomy so that we can't get a good distribution of dose that spares the heart, spares the lungs with conventional radiation, and then settings where we're giving radiation for a second time to the same area of the body where there's been previous irradiation of that tissue and the risks are higher.
A lot of great information at this table right now. Doctors, Allison, sit tight for just a moment while we meet another breast cancer patient. Autumn Early had a routine mammogram plus an ultrasound. Neither detected cancer, but in a matter of months, she would be diagnosed. Here again is Janine Kiesling with her story.
I have so many people keep telling me how strong I am, and it's not that I'm trying to be strong. It's just I have 4 kids that need me.
41-year-old Autumn Early was shocked when she learned she had breast cancer. Autumn's grandmother passed away from breast cancer in her 50s after beating it a decade earlier. Based on her family history, Autumn had genetic testing and was told she had less than 1% chance of getting breast cancer. 2 years later,
I went in for my annual mammogram. They did an ultrasound. They said I had some cysts they were watching, but I was good to go, and I left and was happy that that was over.
That was last October, and then Christmas Day, Autumn woke up with pain under her arm. When it persisted, she made an appointment with her doctor. Autumn was told she likely had an infection and was given antibiotics. Despite the pain continuing, Autumn convinced herself it wasn't breast cancer. How could it be?
Every single little hint that I had, I pushed it off as something else because I had had the genetic testing. It had said I had 0.4%. I just had a mammogram, so it couldn't be that.
But follow-up tests proved Autumn's fears. In February, while on a ski trip with her family, she got a call confirming she had breast cancer. In just a few short months, Autumn went from a clean bill of health to a diagnosis of triple-negative breast cancer. While still on vacation, she called her priest for guidance.
He said, I deal with a lot of people who have cancer in my profession, and he said, KU is where you need to go. And so I left there feeling like, okay, that was decided for me.
A week later, Autumn started chemotherapy on, as it turned out, Triple Negative Awareness Day. Autumn says her treatment at the University of Kansas Cancer Center has been amazing, and she is thankful to her doctors and all of the staff. She hopes her story inspires other women to always listen to their body, no matter what.
What women need to know is just to trust their instincts, and regardless of the tests and what they may have said a month ago, if you feel like something isn't right, get it checked out.
We want to welcome Autumn to the program. Autumn, thanks for being with us. How are you feeling?
I'm feeling really good. It's been 2 months since I've had my last chemo treatment, and my strength is getting better. The side effects from chemo have subsided, and I feel normal again.
So what else is involved in your treatment?
Well, right now I'm just recovering from surgery that I had a little over 2 weeks ago. And I'll be going in to talk to Dr. O'Day next week, but it looks like I'll probably be doing some immunotherapy and some continued chemo treatments.
Dr. O'Day, help us understand the genetic side of breast cancer. When Autumn's test said less than 1% chance, what does that mean?
Genetic testing, we know, can help us understand what is the likelihood that a woman may develop breast cancer over the course of her lifetime. But it certainly doesn't tell us if a patient will or will not. And so we still have to do all of the basic screening regardless of those test results. And Autumn did the right thing by, as she said, listening to her body and seeking out care.
How does triple negative breast cancer respond to standard therapies?
So triple negative breast cancer, we always say we have to treat it a little bit more aggressively, but that treatment tends to work better. And so in Autumn's case, we saw a great shrinkage of the cancer with the treatment. We were very happy with the response, and that's something that we hopefully see in triple negative breast cancer. Luckily, we were able to add in an immunotherapy, which is a relatively newly approved strategy for triple negative breast cancer that we hope increase the response rate for Autumn, and it's one that will continue as a part of her maintenance after her because she's completed her surgery.
So Autumn, you had a choice between a single mastectomy and a double mastectomy. What did you choose?
I chose a double mastectomy, and that reason is because I had been told a few years ago by my doctor that I had dense breasts, and that makes it harder to detect breast cancer. And sure enough, I do believe that's probably the reason why it didn't show up in my mammogram. But then a couple months later, I felt the lymph node under my arm. And so just to reduce the risk of that happening to me again, I chose to have a double so that I don't have to worry about that again.
Dr. Wagner, what else is involved in Autumn's surgery beyond the mastectomy itself?
We have some very new surgical techniques that, fortunately, Autumn has benefited from. The benefit was this new procedure called immediate lymphatic reconstruction, what we oftentimes call ILR. And that's because the more lymph nodes we remove, when we have to remove all of those lymph nodes, there's a higher risk of lymphedema. Lymphedema is an arm swelling that patients can get after having lymph nodes removed. But this new technology literally takes veins in the armpit area and reconnects it to the lymphatic channels by one of our microvascular plastic surgeons. And fortunately, we now have the opportunity to do that procedure at the same time as the lymph node surgery, which has early data across the country has shown very promising outcomes for reducing the risk of onset of lymphedema.
And when does reconstruction come in?
Well, we always want to take the opportunity the same day as the mastectomy. By pairing with our plastic surgeon same day as the mastectomy, it allows us to preserve the skin of the breast, sometimes the nipple when appropriate, as well as the natural curves of the breast. By us being able to say that there's no other skin on the body like the breast skin. It's just the way it is. It's how God made us. But by us being able to preserve that, it really helps enhance the final cosmetic outcome for the patient.
Interesting. Dr. Stecklein, so how does surgery influence the radiation plan? Is it different for someone who gets a lumpectomy versus maybe somebody who gets a mastectomy? How does that work?
It often is. And so for most mastectomy patients, the reason we're doing radiation therapy is to eradicate deposits of cancer cells that might be in the lymph nodes that drain the breast. So Dr. Wagner talked about the process for sampling or dissecting many of the lymph nodes under the arm, but there are other lymphatic drainage pathways for the breast as well. So there are lymph nodes that sit next to the sternum between the ribs and lymph nodes above the collarbone in the low part of the neck. And it's really morbid to surgically dissect and remove those lymph nodes, and radiation treatments to those areas can eradicate those deposits of disease, reduce the risk of recurrence both in the breast and the lymph nodes, reduce the risk of the cancer spreading elsewhere in the body from those uncontrolled deposits of disease, and help contribute to improved survival.
Autumn, you've said you're not alone and that having breast cancer is like being a part of a big club that no one wants to be a member of. What kind of support comes from knowing and being around patients like you?
I had so many people reach out to me that I didn't even know that just wanted to support me in any way they could. They have sent me cards throughout this whole journey. I get little gifts on my doorstep that just are things that helped them through treatment, and they hoped that it would help me. And I've just been so blessed by all the people that I've had. And I hope that I can be that for somebody one day. I hope to pay it forward and support others just like I was supported.
Well, we love answering questions directly from our community, and today we're sharing some of the questions that our staff hear frequently. And Autumn had mentioned that she has dense breast tissue. What does that mean?
Well, dense breast tissue, unfortunately, people think it's how your breast feels, but it's not. It's how it looks on a mammogram. And when we're young, we're supposed to have dense breast tissue for them to serve the purpose of nursing that they are supposed to serve. But as we get older, they're supposed to become more fatty replaced. And that fat allows more of the light to shine through and makes a black background. Well, cancer is white because it is dense. However, there's about 40% of patients that never go through that evolution through the breast tissue changing to be more fatty replaced, and their breast tissue remains more dense. From a radiologist standpoint, being able to find a white dense cancer and a white background of dense breast tissue, it's like finding a cotton ball in snow. We here at the University of Kansas Cancer Center have a couple of additional newer technologies through MRI, abbreviated MRI, which is at the forefront of new supplemental screening, which is excellent for dense breast tissue. We also have contrast enhanced mammography. Some patients can't tolerate or for other medical reasons can't undergo MRI, where we actually do the mammogram and add contrast in that situation. And it has been a great enhancement to all the tools that we have for dense breast tissue.
So we've spoken about this before. Black women are 41% more likely to die of breast cancer than white women. One of the questions that was asked is, what's driving that statistic? Why is that?
One of the things is we see lower rates of screening amongst Black women, and so there has to be huge efforts at helping, educate and make screening widely available to all women everywhere. It's critically important. We also know we're learning there are some genomic alterations that happen within breast cancers cancers that seem to be maybe more prevalent amongst Black women. We also know that some of the testing that we frequently rely on, things like genomic testing or where we look at the DNA of the cancer, that may be influenced by race as well. There's been some data presented recently at our largest cancer meeting that some of the tests we frequently rely on maybe aren't as applicable to Black women. And so we're using that information because it's the best information we have, but we all need to do better in this regard.
Trying to make those changes.
Yes.
I want to get today's takeaways from our guests. And Allison, I want to start with you. What do you want folks to take away from your story today?
Not knowing what's going to happen is the hardest part. So if you are out there and just recently diagnosed, I hope it gets better for you like it did for me with being able to understand the diagnosis and what treatment plan is ahead of you.
Autumn, what's your message to anyone watching?
I would just say, and I know I've said it before, is just you're your biggest advocate. And so just going with your gut instinct and pushing for more testing if you feel that that's what you need to do. Just to even have peace of mind that and answers to what may be symptoms that you have at the time.
Ladies, thank you so much. We appreciate you sharing your stories here today with us. Dr. Stecklein, final thoughts today. What do you want folks to really get from this conversation?
That having a team surrounding you with every piece that you need to have a successful outcome is so important.
Dr. O'Day, what's the takeaway?
Often patients come for a second opinion, but they do so after they have already begun treatment at their local facility. And I would encourage everyone to try to get that second opinion as soon as possible. Oftentimes, once treatment has already been started, that patient may no longer be eligible for a clinical trial that would have been a really fantastic option for them. So really to try to take, when you hear that cancer diagnosis, to try to take a deep breath and then to move forward in a thoughtful way and getting that second opinion and making sure, as Dr. Stecklein said, that the diagnosis is correct, that the treatment is optimal for that person's cancer diagnosis.
Dr. Wagner, wrap us up.
It's a little bit bringing, I think, what everybody has already said. I always tell patients what Autumn illustrated so well. Be your own advocate. Even if somebody says you don't need a biopsy, sometimes you can go into providers and they say, oh, you're too young, you're too this, you're too that. You are your person. Nobody knows you better than you. So follow that gut. Never think that a place like the University of Kansas Cancer Center as an NCI designated cancer center is too big or too out of reach for you. We are in everybody's backyard one way or the other. And you deserve this level of care. You deserve this, and go after it. Ask for help, reach out, and we will find help for you. We have incredible resources to help patients get here to make sure they're always getting the very best care they can get.
Thank you, doctors. Appreciate you so much. Thanks to all of our guests, and thanks to you for watching. Coming up next week.
No, baby should have to go through something like that.
A baby with brain cancer, surrounded by love.
I see you. Thank you for my morning smile.
Her little life is counting on them to do everything that she needs, and people show up and care and love for her beyond any expectation I could ever have.
The proton radiation perfect for patients like baby Kamaya.
If you're 40 years of age or older, get the peace of mind you deserve by scheduling your annual mammogram with us. Our breast-dedicated radiologists read only breast imaging, and they read more than 31,000 mammograms every year. Schedule your mammogram today online at kucancercenter.org/mammogram or text MAMMO to 913-588-1227.